Hello, and welcome to today's webinar, a case study with Shatterproof and Kolmac Clinic. I'm Deb Adler, a senior associate at Open Minds. I'll be serving as the moderator and presenter for today's exciting discussion featuring Dr. George Kolodner and Gary Mendell. I want to start with just what the objectives are for today. We'll give you a little bit of a baseline knowledge about the history and trends that have contributed to the current U.S. opioid epidemic. We'll just give you some statistics related to opioid use, overdoses, and overdose-related deaths. But I want to cede most of the time to our two guest speakers who will talk to you about their partnership with payers, health systems, and healthcare providers, and what they're doing within their organizations to help combat this issue related to substance use disorder. I want to turn the ball over to Gary, who's going to give you some overview of Shatterproof and what they're doing in this space. So I'm turning it to you, Gary. Thank you.
Great. Well, thank you for having me, and welcome to all of you, and thanks for joining. So I'm going to be talking about what Shatterproof is doing to improve the quality of care. Just a quick introduction to Shatterproof. We're 6 years old, and we began our work with policy change, which you see there on that slide, and also in creating community events around the country to build up our engagement of people all over the country as advocates, supporters, and followers of what we're doing with our research and our implementation. We've also created the largest event series in history. We have 7 walks around the country that will engage about 20,000 people this year. Again, bringing people together to engage with our cause. And a lot of it is around stigma reduction, which I'll talk a little bit about later. You know, one of our goals, obviously, like all of you on the phone, is to treat addiction like any other disease. The big thing that that is really missing here, I believe, and I know many of you believe as well, is that there's a large variation in evidence-based practices. My history is my career was in business, not in healthcare, and my older son, Brian, struggled with addiction for 8 years, 8 different treatment programs. And probably if I had to pick out the most common advice I received from 8 different treatment programs was, your son is in good hands with us. Gary, stay out of it. Stop reading, stop learning, and he's in the right place. Well, tragically, my son died. My son passed away 8 years ago, last Sunday, a couple days ago. And coming out of that tragedy, you know, one of the things I did to lift myself up was start to try to understand what had happened. How had I allowed this to happen? And I started digging into the research. And what I found in the months after my son died is that our federal government had given out grants of tens of billions of dollars to researchers all over the country in the decades prior to my son dying. And those researchers had used the money effectively and created this body of knowledge that could be used, that had proven without any doubt to be able to significantly reduce the number of our loved ones who ever become addicted, and another body of knowledge that had proven through clinical trials to be able to significantly improve the outcomes of those in treatment, whether it's for opiate use disorder or broadly substance use disorder. Yet all this information was in peer-reviewed medical journals, and hardly any of it at that time was in use. Some was, but not broadly across our country throughout our healthcare system. So that led me to starting Shatterproof. It led to our beginning work in policy. It led to our beginning work in creating events to engage people around the country for stigma reduction. But it also caused me to then, several years ago, to look at how we really changed the treatment system in the United States. And we created a 5-point action plan to do so, to significantly improve the quality of and the access to addiction treatment. Really five-point plan there. Number one national standard of care. And I knew from my experience in business that if we were going to be able to get broad dissemination of a standard of care, it had to be less than 10 core principles. Because most businesses in America, you don't bonus people on 20 or 30 or 40 things. It's always less than 10. What's the 80-20 rule? What are the core things that every treatment program in the country, or every provider in the country should be delivering? Whether it's inpatient or outpatient, whether it's adult or adolescent, whether it's opioids or alcohol, what are the core things? So when the Surgeon General's report came out in the fall of 2016, we saw that as an opportunity to there was one report with all the research in it. It was unarguable because everyone had, most federal agencies and experts had signed off on the report. We took content out of there and drafted, working with Pew Charitable Trust and some of the leading researchers in the country. And we drafted 8 core principles of care. And then we were successful in having 21 insurers representing approximately 250 million lives commit to our principles and commit to aligning their payment policies to be consistent with our national principles. So that was step one. Then quality measurement, which I'm going to talk extensively about in a few minutes, payment reform, building capacity in our system, and stigma reduction. So the 5 points of our plan. And there on the slide is our national principles of care. And for anyone that would like more information on them, they're on our website. So as I mentioned, 21 health insurers have now signed on to our principles of care. So then we move into, I'm going to spend a lot of time on quality measurement systems. So I'm going to move through a few others now. Payment reform and treatment capacity. I put those on the same slide because that's being handled by our public policy team. Those are public policies. Creating payment systems that align with efficient care, because it's not appropriate or fair or workable to expect providers to deliver quality care if they're not paid the right way to do so. Treatment programs, treatment providers need to be paid in a way to facilitate their easy ability to deliver quality care without barriers. And so we've been working on policies around the country to do that. And then as far as treatment capacity goes, in contrast to payment policies, which we're working state by state by state, and also with commercial payers, for treatment capacity, we're working on some national levers to get basic training in addiction prevention and treatment into medical schools or residency programs. And we're working on a couple national levers right now to be able to do that. And I also can't talk about at all, it would just be wrong to talk about improving the treatment system in the United States without speaking about stigma. We know that approximately 20% of those people in this country who have a substance use disorder have reported one of the reasons that they haven't sought treatment is because of stigma. They're afraid if they seek treatment, if they run it through their insurance, their employer might find out, and their career might be changed or altered. They know that if their friends find out, or their neighbors, or anyone in their social network, it could affect that social network. If anybody finds out, they're going to treatment. We know that those with this disease, if they get past that hurdle and they decide to seek treatment, sometimes treatment is not covered in their health benefits for addiction the way it is with other comparable diseases, and they may not be able to afford it. Or if they can get past that hurdle, then they have a hard time finding treatment sometimes because in many places in the country, you can't find a provider. Less than 50% of the counties in the United States have a provider who's licensed to prescribe buprenorphine. Well, why? That's not for other diseases. That's because of stigma. And then if a person gets through all of that, they get to treatment and it's quality treatment, then they enter a world where 20%, the bottom one I think is most important, 20% of Americans in a recent poll are willing to associate closely with someone who's addicted to prescription drugs as a friend, a colleague, or a neighbor. So even if you get treated fully and well, and you're in recovery, able to successfully manage a chronic illness, you're in a society where most people don't want to associate with you. So stigma is absolutely a big part of this. It's out of the scope of this call to go any further on it, but we're going to be launching a national initiative on this later this year and early next year. And if anyone's interested, please reach out to me because we've spent the last 6 months studying all the research about how our country changed its views on HIV/AIDS, marriage equality, domestic violence, etc., and have developed a national framework with action plans for stakeholders to significantly reduce stigma based on what has worked for other social movements. So again, anybody interested, feel free to reach out to me. And just to finish up on stigma, we're looking at social, self, and structural stigmas. We're initially focused on those addicted to opioids. It's informed by all the research that I just mentioned, a portfolio of initiatives with identified partners, and validated research to inform our continual iterations. So for the rest of this call, I'm going to focus on our quality measurement system that we've created. So quality measurement, it's a platform that provides what we've designed. We were successful in receiving $5 million in funding 2 years ago, or a year and a half ago, and we have we are building a system, and phase 1 is going to be in 6 states. So it's a system that will provide reliable and transparent information to, as you can see there, 5 target audiences. And we believe phase 1 we begin to create a standard of quality across the addiction treatment system. As I just mentioned, we're piloting in 6 states, and then we'll begin phase expansion, and we're already starting to talk about our additional 6 states to expand. For states that are interested, in addition to when we approached the first round of states, we're looking for 3 things from states. Number 1, to commit to, we have 4 measures that are based on claims data, and that information will come from commercial claims and Medicaid data. So for every state in our pilot, they have agreed to calculate 4 claims-based measures using their Medicaid data, and then send that information to us to go into the quality measurement system. The second thing that states agreed to, each of the first 6, was to work with us to engage stakeholders in their states, whether it's providers and other payers, and also to promote Atlas to those living in their state. So once it's launched, the public is aware to it, to go to the website and be able to determine the different quality metrics of different treatment programs in their state and compare them to each other. So we also, if we look at our target audiences, the 5 I mentioned there, we did focus groups and discovery with each of those target audience to see what they really wanted from our quality measurement system. Patients, no surprise, and family members, no surprise, they want simplicity. They want a composite rating, such as a STAR system. They want to be able to filter by geography as well as what insurance they have, and ability to compare programs. We then, with that, we also developed our measure set. So the first thing we did with our measure set is that we, right after we finished the principles of care, we formed a measure committee with experts, and those experts crosswalked a set of existing measures that were out there today for health plans and put them into the same buckets, if you will, of our 8 principles of care. And then they created other measures that were out there, or they looked at other measures that were already existing and populated it. Then we did key informant interviews with payers and provider focus groups to tweak, narrow down, amend, revise the original set of measures. Then we retained the National Quality Forum, which ran an expert panel. The input was the existing set that we had after it had been tweaked through the key informant interviews, and then the experts then ran a process to revise them again for a third time to come up with a final set. So where are we now with the measures? We have 3 sets of information coming in: claims data, which is both commercial and Medicaid; patient experience information, and there we're using CAHPS questions from AHRQ, and we tested it in 50 programs in the state of New York, and it worked out far better than we expected. We had great participation, and the information that came out looked to be really valid and reliable because it was very consistent across each particular treatment program. And then we have iterated and finalized. This slide is a little bit old because all this is done now. So the claims data measures have been tested and completed. The patient's experience survey is now, that was done and completed and went great. And then the treatment facility survey is now done. And we started collecting information actually 8 days ago, a week ago yesterday. So there's four of the measures are claim-based, and you can see them there. I won't go through them now to save time, but again, if anybody wants more information, just feel free to reach out to us and we will get you anything you'd like. So again, 4 claims-based from the previous slide, and then we have 7 measures plus a patient narrative that are all adapted from CAHPS from AHRQ. And you can see 4 of them there, and you can see the remaining 3 there with the patient narrative. So the treatment facility survey, that gathers information from treatment programs, which we can then verify, and it's completed by the facility level. We were very focused on the intersection of valuable information with any burden it would put on providers to give us this information. And we ended up with a survey that the constituents, the target audiences that are going to be looking at the information, were pleased with the information we were gathering. And we have a provider burden that's approximately an hour or an hour and a half once a year, which we believe is appropriate.